Okay, so patient selection then. Well, so far we've talked about what sedation is and the levels that we might want to achieve. But a key element when we talk about procedural sedation is actually choosing the right patient that would potentially benefit from it. And also, as they've just mentioned a few minutes ago, we want that patient who's at low risk of harms or complications that might occur. Now, before I start this section, I really just want to talk to you and make you think about, have you actually maximized all of your treatment options prior to actually needing to sedate that patient? And what I mean by that is, have you tried all of the tools in your arsenal? So have you tried the non-pharmacological methods of things like anxiolysis, so things like parental holding that we've talked about? Also, is there anyone more senior that could potentially help you or might have additional skills? So thinking about specifically about things like approaches to procedures like anterior shoulder reductions, for example, that aren't painful. So stuff like the Cunningham method or the Fares method. And these are things which you might not have in your skill set yet, but actually someone more senior might do, or someone might have a different approach to avoid doing this sedation in the first place. And the final thing, just before you get started, is there a new approach that you might not be aware of yet? So ask a friend. So I can remember the first time I saw a modified Valsalva for an SVT. So just be aware that practice can change and other options might be available to you that you've not yet come across. So ask around, see if there's anything you can do to avoid it in the first place. Now, presuming that we've tried those and we've maximised all of those elements, well, let's think about the indications for procedural sedation. So just to make sure all of us here are on the same page. Now, if you look at the literature, the most common interventions that are performed under procedural sedation are orthopedic procedures, somewhat unsurprisingly there, and this is by far the most common indication in the emergency setting, accounting for somewhere between 75 and 95% of all the cases in which sedation is done. So the sort of things that we're talking about here are manipulations of dislocations, so ankles, shoulders, and potentially hips in some regions, and reduction of fractures, so femurs, ankles, tib, fib, and potentially upper limb injuries like Colles fractures or forearm fractures in children. So orthopedic procedures by far the most common indication. The second thing is things like DC cardioversion for tachyarrhythmias, so particularly thinking about those who have adverse signs nowadays. But historically, even without adverse signs, we did do this a lot for new onset AF, but due to recent evidence, we tend not to do that quite as much in the ED as we used to. Now, finally, there is a sort of miscellaneous category which encompasses other needs, such as, things like dressing changes. So thinking particularly about painful stuff like burns dressings, or potentially chest drain insertion, which is obviously and can be quite distressing for some patients. And if you can't get appropriate local anaesthesia there to keep them pain-free. Clearly, there is a pretty big scope for procedural sedation in terms of the indications then. But the take-home point regarding indication is that you can really consider it appropriate or indicated, in inverted commas, for any procedure that a patient might find unpleasant or painful, particularly as it can avoid those memories associated with those procedures. So really simple in terms of indication: any procedure that the patient might find unpleasant or painful because it makes them forget about it. Now, what about contraindications? Because these two come hand in hand, don't they? Well, in certain contexts and conditions, procedural sedation might not be appropriate. So the sort of things that we're thinking about here are cases where you don't have appropriate monitoring and resuscitation equipment available. So in hospital, this might be due to capacity issues or exit block. Out of hospital, if you're in a resource limited, e.g., multiple casualties, or in locations where you don't have full access, e.g. the side of a mountain or on sloping ground, then clearly it might not be possible to achieve procedural sedation safely. The next thing really is considering the patient's needs, which might be greater than what you can perform under procedural sedation. And what we're talking about here really is brief procedures when we think about procedural sedation. So if your patient has complex wounds or multiple orthopedic injuries that need managing, then general anaesthesia and theatre is the thing that they need, not a prolonged procedural sedation, which is one of the elements associated with pulmonary aspirations. Patient allergies, so that's kind of self-explanatory, so you clearly don't want to make this situation worse. The reason I've added this, though, is that there are some common misconceptions, particularly regarding some of the drugs that might be used, for example, propofol. So propofol was contraindicated for those with an allergy to egg or soy products, as it is made with soybean oil and egg lysine, which is a fatty substrate. However, patients who are allergic to soy and eggs are allergic actually to the proteins, not to the oils or fats. Now, the theoretical risk is that it might have some residual protein, but that has never actually been supported by any data or studies. In fact, it has actually been used safely in those with positive specific IgE response to egg and soy. So in summary, it's essentially safe in that group with regard to egg and soy risk. Now, back to the contraindications. Well, one of the biggest will be about the operator skill set. And by this, we mean the person performing the procedural sedation needs to be able to recognize and treat adverse events and have competence relating to airway management. So if that is not possible and that is not within your skill set, then again, this is a contraindication. Now, thinking specifically about patient conditions now, and this is one of the things that comes up in the literature a lot. Now, patient conditions, for this we need to have some awareness of something called the ASA, or the American Association of Anesthesiologists grade. So the ASA grade for the patient that's in front of you needing that procedure and that sedation. So an ASA grade 1 you will hear talked about, and that is a normal, healthy patient. Okay, so that's a normal, healthy patient. An ASA grade 2 are patients with mild systemic disease. So this is well-controlled disease, single system involvement, no functional limitations. So examples of that might be sort of COPD that's really well controlled, mild obesity, or in fact actually in pregnancy. So you have some mild systemic involvement, but actually it doesn't generally cause them any problems. Now, ASA grade 3, so this refers to patients with severe systemic disease. So some functional impairment, controlled diseases involving more than one system. So, for example, congestive heart failure with a history of a previous MI. Now, this is getting worse as we go on, so your ASA grade 1 is the best that you're going to get. So we're on to ASA grade 4 now, and this is for patients with severe systemic disease that represents a constant threat to their life. So this is chronic problems like congestive heart failure or COPD that are not well controlled, so those patients that are recurrently attending EDs and requiring admission for their management. So ASA grade 5, so this is moribund patients with multi-organ failure and hemodynamic instability. And the final grade is ASA grade 6, which is a patient who's been declared brain dead and is awaiting organ harvesting. So not typically the sort of patient that we will encounter in the ED or pre-hospitally. Now, typically, those patients with an ASA grade 1 or 2 would be classed as suitable for an emergency procedural sedation. Certainly where I work, it is a requirement that you need to have anaesthetic support if you're doing a procedural sedation outside of these groups. So in the literature, just to recap, we're talking about predominantly ASA grades 1 and 2 that are safe for emergency procedural sedation, and those are normal healthy patients or patients with mild systemic disease. Now, this is because, and the reason that when you go higher on these ASA gradients, the reason we tend to avoid it or require additional support is because they have greater comorbidities, and those comorbidities are associated with greater risk of aspiration in those undergoing procedural sedation and those having general anaesthesia. Now, the final point regarding contraindications is something which comes up a lot, and that is regarding fasting and how long does it need to be since your patient has last eaten or drank. Now, if you look at the guidelines for elective general anaesthesia, so these are the patients that come in for procedures rather than the emergency ones that we get, now you will find that they recommend 2 hours for clear fluids and 6 hours for everything else. But clearly that's elective practice and we can't necessarily wait that long in the emergency setting. Now, the first thing to say is that the evidence relating to fasting and procedural sedation is substantially, and I mean substantially less than it is in the elective world. But in a huge multidisciplinary consensus statement, which was published in 2020, Green et al. Stated that there is no confirmation that pre-procedural fasting has a clinically important impact on preventing pulmonary aspiration, and that the overriding focus on fasting is largely misguided in procedural sedation. So that focus that we've been having on fasting is largely misguided, just to recap that. Now, their recommendation in that consensus statement is that, in fact, what we should be doing is spending more time establishing the correct ASA grade rather than focusing on how long they've been fasted. So I think the overriding take-home point regarding procedural sedation is if you have the right indication when you look at this flowchart, and this is taken from that Green et al. Paper that we just mentioned, you can see that there should be no delay for any urgent or emergency procedures based on fasting time. But for those with moderate risk factors, so those ASA grades that are a bit higher, you might want to tailor your pharmacological approach to fit that patient cohort.
Excellent. Well, thank you very, very much for that then, Rob. So what you've nicely done there is picked out how we can select the patient that we're going to choose for this procedural sedation that we're all learning a little bit more about. Well, wouldn't that be hugely convenient if we could pick the patient that was coming in and we could pick which injuries they'd got and who needed sedation? But as we all know, life isn't quite that simple, is it? So I just want to hammer this home in my head. So let's think about the average sort of patient that's going to be coming in. So let's say we've got a 50-year-old male and they've got a bit of hypertension and they've got some diabetes. So can you just recap which ASA grading are they going to be given?
So I think that's pretty clear. You know, a 50-year-old patient with who you've described there seems to me to have, you know, a relatively mild systemic disease that seems well controlled. Obviously, you'd need to just dig into what they're able to do a little bit more, but it seems like they're going to be an ASA grade 2 to me.
And that's taking into account the diabetes as well?
So what I would say by that is, so in terms of the ASA, so it does say that it has single system involvement. However, when you think of the difference between ASA grade 2 and grade 3, so grade 3 is quite a big jump. So it's patient with severe systemic disease and with some functional impairment. So whilst you could consider potentially that diabetes and hypertension involve two systems, I think really it's more to do with the mild systemic disease and the fact that it's well controlled, and hopefully there are no functional limitations. Those would be the two take-home points for me.
So you certainly mentioned that orthopedic procedures are going to be probably the vast majority of things that we're going to be using procedural sedation for. But let's just consider those sedations that actually have a real immediacy and urgency to it. So let's say we've got that patient that's presented with VT. They're compromised, so they're showing signs that they're developing some pulmonary edema. They're a bit shocked. Their blood pressure certainly isn't looking too good. Let's say they've got a blood pressure of 80/40. They're looking pretty grey and they're pretty sweaty. And you work in one of these standard EDs, which is really busy. You know, you can certainly get hold of other colleagues to call them down if you need some support, but it probably isn't going to happen that quickly. So what ASA grading are we looking for with that patient?
So, I mean, largely, I think you've got a patient that is circling the drain here, haven't you? So, I mean, essentially, it's largely irrelevant what ASA grade they are, because this patient is going to die unless you do something to treat them. I think that's the point that you're trying to get at with regard to the low blood pressure, the looking grey, they're about to fall off the perch. Would that be fair?
I'm just trying to make it as awkward as it possibly could be with regards to the statement that you came up with. But you're dodging the question a bit here, really, Rob. What ASA grading is this patient?
Yeah, okay. So I will admit I was dodging it a tiny bit. But so this patient is clearly, clearly really sick. And if you go back to that ASA grade, well, moribund patients with hemodynamic instability. So that's an ASA grade 5, isn't it? Now, we said a few minutes ago that, ASA grade 1 and 2 are typically the patients that we'd consider appropriate for procedural sedation. But this is a patient who's unwell. So they're circling the drain. they're getting sicker and they're not going to get better, are they? Let's face it. So here we're faced with a decision, and that decision really is based upon a risk-benefit analysis. And this is where it gets a little bit more complicated. So when we look at the sort of risks for patients that have had a procedural sedation, what we're looking at are the risks to them in terms of things like pulmonary aspiration. Now, this patient may well have an element of risk with regard to pulmonary aspiration. However, they have an absolute definitive risk of death because they're not going to tolerate this ventricular tachycardia for a very long period of time. So we then have to make a balanced judgment based on a risk-benefit analysis. And that's when really we have to step away from the procedural sedation rules that we would ordinarily use, and actually it's based on a threat to life, is essentially the way that I deem it anyway.
So what we're talking about here is an ASA grade, which traditionally, and I purposefully made this awkward for you because it's great to see you squirm, but what we're really talking about is the fact that this is very different, isn't it, to somebody that has got a fracture which needs manipulating, who's got an ASA status which is a lot higher, as opposed to somebody that has got an ASA status, which again we're saying here is 5, but has got a real need from a life-threatening point of view to get sedation so that they can get that treatment that they actually require. So yeah, I think that nicely answers the question.
Phew. Well, thank you for obviously letting me off the hook a little bit with that. So in summary for patient selection, so always think about, have we maximised everything we can do that's outside of actually performing a procedural sedation? Because that is pretty key, and there might be some things that you might not have heard about, so ask around. Now, with regard to the indications, it's pretty simple. So it's a procedure that the patient might find unpleasant or painful, and you want to try and avoid the memories associated with those procedures. Thinking about contraindications, so just be aware of the sort of things that you might want to avoid. So make sure you've got appropriate equipment, make sure the patient's needs are appropriate for that, as in a short procedure rather than a long one, and make sure that you've got the skill set you need around you. When it comes to the actual choosing of that patient, it depends a little bit on the condition that they've got, but ordinarily in a stable patient that has a indication that could wait a little bit, we would ideally look for an ASA grade of 1 or 2, so a normal healthy patient or one with mild systemic disease. But if that patient is sicker and they need to have an intervention done sooner, then we need to do a risk-benefit analysis no matter what they look like.